Every minute, someone's life takes a terrifying detour, not down a dark alley, but into the sterile, bright halls of healing. They walk in seeking care and find themselves plunged into a nightmare. Most malpractice claims in hospitals are related to surgical errors, whereas most claims for outpatient care, which accounts for more than half of the paid malpractice claims, are related to missed or late diagnosis. Now, before you raise a pitchfork at every white coat you see, let's be clear. This isn't an indictment, it's a revelation. Because the truth is, any provider, any nurse, any human being capable of brilliance is also capable of a mistake. This is about understanding why and using that knowledge to build a safer future for every patient who walks through those doors. Welcome to FHEA's Scrubs and Subpoenas, Tales from the Witness Stand, a podcast where we'll peel back the sterile sheets and delve into the real stories of medical malpractice. Each episode, a cautionary tale, a blueprint for change, a reminder that even in the darkest corners of human error, there's a light. The light of knowledge, the light of empathy, the light of a future where healthcare becomes not a gamble, but a guarantee. So join us as we dissect the mistakes, illuminate the flaws, and ultimately learn to heal not just bodies, but the very system itself.
So, all right. So that was early. That was early in we'll say I'm not giving away too much. I can say August. I say early in August. All right. Okay. So apparently the patient does go on the next day. The patient has that was late in August. The next day, the patient saw a physical therapist. I don't know how she got in that fast, but the patient saw a physical therapist the next day. Physical therapy actually did a very thorough assessment and documentation. The physical therapist documented the history of the pain over the last year, that it had been intermittent, that it had early on resolved with nonsteroidals, but over the last few months, it had become constant and intolerable. Physical therapy documents left leg numbness and tingling, stomach numbness. Okay, it's PT. The anatomy might be a little, but yeah. I'm assuming abdominal numbness because nobody went in there and felt her stomach. But left leg numbness, stomach numbness, and the patient reported a recurrence of the knot in her back. Oh, remember I said a couple of years ago she had a thing removed? Yeah. So the physical therapist physically inspected the back and noted the presence of blisters and opined that the patient might have shingles. The physical therapist also documented a cyst-like mass along the region of thoracic pain. Oh. So this is this is the day after the NP saw her, and the physical therapist is documenting a cyst-like mass along the region of pain, the presence of blisters, and that the character of pain in recent months has become constant and intolerable, and that there is numbness and tingling. So again, this note, it's really in contrast to the note of the day before.
Oh yeah,
and it just doesn't sound good. Yeah. So of course, it makes you wonder. Now, of course, the plaintiff's attorney just suggested that this all happened overnight. Yeah, but and that's for a jury to decide. Anyway, PT recommends an MRI. Remember I said like a consultant, they technically only have to stay in their lane, but if a consultant sees a real need for something, they will usually make that opinion. So anyway, the PT, that was on August 31st of X year. So I'm not giving away too much here. Sure. So that's that. So now the NP doesn't actually see the patient again for like 2 weeks, but via social media communication, based on the physical therapist's input, the nurse practitioner enters into the chart a diagnosis of shingles, puts the patient on a cyclovir and gabapentin, and that's it. So, September 1st, the patient's, this note is entered into the chart, a diagnosis of shingles is made, the patient is started on a cyclovir and gabapentin, and follows up in 2 weeks.
Based off that note
at the 2-week follow-up from the physical therapist, yeah.
Okay.
2 weeks later, the patient had no improvement. So finally, at the patient's request, the MRI was ordered on the MRI was performed on September 21st. It was ordered like on the 14th. It was performed on September 21st. So the MRI, I wrote it down. The MRI demonstrates 2 large mass lesions in the thoracic spine, worrisome for a malignant neoplastic process, extending into the chest and displaces the thoracic aorta. Second lesion is associated with a severe compression fracture of T4. The mass completely surrounds the spine at T3 and T5.
I have goosebumps behind my ears. That's nuts.
And so, the first thing that's a real takeaway here is the numbness might not have correlated to the location where the patient perceived the pain, but this lesion is wrapped around the cord at multiple intervals. So clearly there is impingement of the cord lower down to coordinate with the numbness. Yes. So just because somebody tells you it hurts, like wherever, don't just assume that that's got to be where the nerve impingement is, because the process inside can be really different and extensive. She also had a severe compression fracture of T4. So, the compression fracture, you might be thinking, really, a lesion can cause a compression fracture? Well, we'll get there in a second. But just the fact that she had a compression fracture, they really, really hurt.
Yeah.
And if you had palpated that area, it probably would have hurt her. Again, we don't know what was done versus what wasn't documented, but it's just such a discordant story along the way. And so anyway, now there's even more to consider here. The MRI report of the 21st is, as I just read it to you. On the 25th of September, the NP begins to initiate arrangements for a biopsy. So it's like the surgeon for a biopsy, but oncology because it's suspicious for malignant neoplasm. And it's like oncology won't even see the patient till the biopsy is done. There was a bunch of back and forth here. And I'm editorializing. There was actually back and forth with, well, this oncologist, wouldn't see them for X number of weeks. And then the patient was getting concerned, and the patient had a relative who worked somewhere. So the patient starts trying to navigate her own thing. Finally, anyway, the biopsy is done in October, early October. So we've gone from an MRI with this report in like the 3rd week of September, and the patient's still out walking the street, not literally, but just out, living life, has a biopsy on 10/4. The biopsy, along with other records, the biopsy result is forwarded to the oncology service, who, as soon as they see it, they call the patient. The patient had an appointment coming up, but the oncologist called the patient at home and said, go to an emergency room right now.
Oh, how scary.
And the patient went to the emergency room right then, and she had her surgery that day, like immediately.
Wow.
And so she had surgery to try and, dissect out some of this lesion. And then she had radiation. She went under a whole cancer care phenomenon. She survived. The patient survived. Yeah, she survived. She was still alive and, functional and everything and capable of testifying.
Ambulatory and everything?
Mm-hmm.
Wow.
Mm-hmm. At the time of this lawsuit. But, so.
I'm trying not to be fired up. I'm going to be very honest. We just opened up this whole episode saying that we get it. We talk a lot about documentation and these episodes a lot. And this really seems so, just based objectively alone, based off the documentation and what we know, seems so off, so far away from any standard.
Yeah, I consolidated some of it, some of these visitors, but it was stuff that really wasn't relevant. The assertion. So of course, the lawyer drafts a complaint and the complaint is served on the defendant. And the complaint really centered around the back pain not being taken seriously.
Yeah.
And so then the push and pull here as well. Maybe the patient should have been more verbal. If the patient was having pain worsening for the last year, why didn't she come in more often? That's the plaintiff's position. The patient didn't really communicate it this way. But so here's the takeaway message for all of us who are listening. yeah, back pain. Listen, back pain is hard, and we get so much of it, and a lot of it is like psychogenic and stuff like that. So you do have to always be open to a complaint of back pain as having an organic cause. First thing to keep in mind is don't let yourself fall down that hole of, oh God, back pain. Oh God, it's back pain. You just can't think that way. It's not unreasonable in the beginning to think thoracic strain. Now, the weight I really did struggle with because with a BMI of 24.9, like I said, I can't imagine, or 24.5, I can't imagine attributing back pain to that. But like in general, or somebody who doesn't really think about the pathophysiology behind a thing is probably taught, oh, one of the most common causes of back pain is overweight. So that really is like a more superficial approach and doesn't really demonstrate truly thinking through the underlying process here. But okay, even at the first visit, if you call it thoracic strain, that's a fair miss. Okay, it's a fair miss. And the documentation of the exam might not have been perfect, but it's a fair miss. But another thing, and I know I've mentioned this in other episodes, if the patient persistently complains of the same thing and it's not getting any better, there's something there. Complainers, our Munchausen's people, or whatever the contemporary term is, our somatic complaint disorder or whatever, it's always something different. It's not like this lady, she's been back a few times with her back pain and it's always in the same place. And if you can't figure out what's going on, there's something missing. Yeah. Now she's been through Kenalog injections, Ultram, Baclofen, ibuprofen, Toradol. When you have the same complaint and it's not getting better with all of this kind of stuff, like the take home point is look for something else. There's something else going on there. Because if it was somebody who was just being Munchausen-y, it's like this week it's back pain, then it's my abdomen, then it's my leg, then it's my head. Like it's always something a little bit different. So there's that. Aside from that, that visit in August, a year later, where she comes back, and again, it's still really pretty perfunctory here. It's pretty cursory. But the next day, the physical therapist appreciates a cyst-like mass. The therapist appreciates blisters. The therapist, supports the numbness. So it really makes it hard to imagine that the evaluation a day before was an accurate one or a standard of care one,
Absolutely.
Interestingly, remember one of the documentations was tender to palpation, but no skin change.
Yes. And then the PT sees blisters and sees a
and a mass. So, oh my God. So that's problematic. But then another biggie, and it really does, it always stuns me when I see stuff like this, because I see it fairly often, that the MP knows something needs to be done, but the patient one doesn't want to do it. So the MP says, okay, so, remember, if people don't want to do something, we've talked about this on numerous occasions with these cases. If the patient doesn't want to do it, you can't make them do it, but you don't want to give your stamp of approval on it either, because that's what they're looking for. If you give your stamp of approval, then it's okay. So in a case like this, listen, if you feel numb and you have this pain for over a year, you must have an MRI. And the patient says, oh, I'm going to have to drive to the city, or I can't afford it, or the copay's too high. I'm sorry, but you need an MRI. Here's the referral. And then the patient either will do it or won't, but you've got to document that you've advised the patient appropriately. That's a thing there that we all really can learn something from. You can be nice. I mean, I always joke and say, don't be nice. We're not friends with our patients. But you can be professional and respectful and even say, look, I understand, because I have said to people, I get it. Like, I totally understand why this is going to be difficult, but it's what you need. I can't support anything else. I really think you need to do this. And then and then very often the patient's like, okay, oh God, well, I guess I'll do this and this. And then they do it. Beyond that, the other thing here that we all could learn something from is with an MRI report like that, when you see a compression fracture and two lesions that are invasive, displacing the thoracic aorta and wrapped around the spine from T3 to T5, that patient needs to go to an ER. They just need to go to an ER. This is not time to be worried about, well, it's a weekend and, we'll organize and we have to do the referral and I have to hear from them and they won't see you till this happens. No, ER. Got to go to an ER. Got to go to an ER. And I guess that's all. I mean, thankfully, thank goodness that the patient came out of it okay.
That is really something. I mean, we talk so much about documentation, and it is really important. Documentation is so much, but this is one of those stories that it is really hard. It's hard for me, as we like to do in these episodes, to figure out which side you're on. But I can't imagine, Dr. Miller, that you got this and you were like, oh yeah, this was standard of care. I don't imagine that was the case here.
There was a plaintiff's expert, NP, who supported this and basically tried to shift the blame to the patient. Like, well, why did she tell PT that it's been bad for so many months, and if the NP knew it was bad, and listen, yes, in a perfect world, but remember, every time a patient comes to you with pain, you say, oh, okay, what's the strain? You should sit up straight, take Motrin or whatever. You minimize its severity to the patient. So, as the time goes on and the patient's like, man, this really hurts, or, oh, well, let me just take some more Motrin. And listen, days go by, weeks go by, months go by, and you don't prioritize it because you were never given the impression there was anything serious, that it was just uncomfortable. And you try to, like, oh, don't make an appointment. She's just going to give me more Motrin. Like, that's what happens.
Wow. So what ultimately ended up happening with this NP in this case? I imagine did this settle too?
Well, yeah, but it settled because they realized that it was not defensible. So it settled, absolutely. But it was a big money settlement. It was very favorable to the patient. Mm-hmm.
I can imagine. Wow, this was fascinating. This is one of those things that happen that kind of like shake you to remind you that, like, come on, we can't be poo-pooing all these little things.
I know. And it is so frustrating though, because most of the time those little things are little things.
Yeah.
But until that's our job. Like, that's our job. That's our job, is to figure out when it's not. And we're not perfect by any means, but there are these typical axioms, I guess is the word, like, if the same thing keeps presenting and it's the same and it's not getting any better despite everything you try, you look for something else. You can't just write it off to posture, Yeah,
I agree. Wow. Dr. Miller, thank you so much for sharing this story. And I hope everyone who's listening in got some really good takeaways from this. I know I certainly did. I appreciate your time, Dr. Miller. Appreciate you all for tuning in too. We hope you enjoyed that. And if you're looking for more, check us out at FHEA.com to see what other podcasts that we got cooking for you. In the meantime, goodbye for now.
Thank you for listening and learning with Scrubs and Subpoenas, Tales from the Witness Stand, presented by Fitzgerald Health Education Associates. Please rate, review, and subscribe to this podcast. And for more NP resources, visit FHEA.com. Join us again next time as we dissect more medical malpractice cases.